Assalamu alaikum, Dr. Rashid Mahmood here. In this video, we are going to learn the basic concepts, and I will describe it briefly and practically that how you are going to manage the case of nephrotic syndrome. Being a resident, I has had the difficulty getting bookish knowledge and applying it on the patients. So I will simplify all these things and management plan in this video for the nephrotic syndrome. So the basic aim in this video is to simplify the management plan of nephrotic syndrome. Being a pediatrician, you have to manage the first episode of nephrotic syndrome. You have to manage infrequent relapser. You have to manage frequent relapser and even steroid dependent. However, when they get relapse on alternate therapy, or if case of steroid resistant nephrotic syndrome, then you have refer to them to the pediatric nephrologist. Otherwise, you can manage all these cases by yourself. So you all know basic the definition of nephrotic syndrome. Whenever a child comes with you with a complaint of periodal puffiness or edema, genital edema, more aggravated in the morning, child is otherwise active and alert and playful, you suspect nephrotic syndrome. You send labs in the form of creatine, protein creat ratio, urine protein, and dipstick urine protein, and serum albumin level. So if they come as per the criteria that albumin is less than 2.5 gram per dl, urine protein is 3 plus, and urine protein creat ratio is more than 2, and serum cholesterol is more than 200 milligram per dl, then you make the diagnosis of nephrotic syndrome. So after making the diagnosis of nephrotic syndrome, what you will do? So important thing is that you will make that whether this nephrotic syndrome is primary or secondary, and you will make the diagnosis that whether this nephrotic syndrome is typical or atypical. So the management plan depend on that. So how you say that nephrotic syndrome is primary or secondary? For that you will need the history, a good history and examination. In history you will ask about any history of drug intake like NSAIDs, mercury, heavy metal. These all can lead to the secondary nephrotic syndrome. On examination you need further any evidence of lymphoma, SLE. So these all things are also causes of nephrotic syndrome. These are the causes of secondary nephrotic syndrome. Similarly, you will look also for the features of atypical nephrotic syndrome, because the management plan of atypical nephrotic syndrome is different from the typical nephrotic syndrome. So let's review that. The patients may be considered for the steroid treatment prior to kidney biopsy if they meet all of the following criteria. So if this criteria is met, you can directly go for steroid. You don't have to go for biopsy or other tests before nephrotic treatment of nephrotic syndrome. This criteria is that age should be 1 to 12 years, normal kidney functions, so RFT should be normal, no macroscopic hematuria, gross hematuria should not be present. Macroscopic hematuria can present, but macroscopic or gross hematuria doesn't feature of typical nephrotic syndrome. No symptoms of systemic disease like fever, rash, joint pain, weight loss should be present. Normal complement level, hypocomplementemia is seen in the MPGN as well as in SLE. Negative anti-nuclear antibodies and negative viral screen for the HIV, HBV, HCV, and there no family history of kidney disease. So you should first, after diagnosing nephrotic syndrome, you should look for all these points. If none of these is present, then you will directly jump and start the steroid therapy. This is very important point, that you should also go through all these points. Kidney biopsy should be performed prior to an immunosuppressive treatment, including steroid, in patients who meet one or more of the following criteria. If any of the criteria is met, you have to go for the renal biopsy before start of steroid. Age younger than 1 year or older than 12 years. If nephrotic syndrome occur in first 3 months of life, it is called as congenital nephrotic syndrome. From 3rd month to 1 year, it is called as infantile nephrotic syndrome. In this age group, the nephrotic syndrome is usually due to some structure abnormalities, so you have to go for the biopsy. Presence of recurrent gross hematuria, also a feature of atypical nephrotic syndrome. Relevant family history of kidney disease, symptom of systemic disease, and positive viral screen. So any of these is present, you have to go for the biopsy. Children with onset of uncomplicated nephrotic syndrome between 1 and 8 years of age are likely to have steroid responsive minimal change nephrotic syndrome, and steroid therapy may be initiated without a diagnostic renal biopsy. So in this age group, you can go for the steroid therapy without biopsy. Children with features that make minimal change nephrotic syndrome less likely, like gross hematuria, hypertension, renal insufficiency, hypocomplementemia, or age less than 1 year or more than 12 years should be considered for the renal biopsy before the treatment. An evaluation to rule out secondary forms of nephrotic syndrome in children more than 10 years by the complement C3 level. So you have to, if you want to rule out the secondary form of nephrotic syndrome, the workup is complement level, ANA, anti-dsDNA, HBV, HCV, HIV in high risk population, and kidney biopsy for children more than 12 years who are less likely to have minimal change disease. So first you will diagnose nephrotic syndrome. Second, you will go through the first slide that I've shown, that the child is fulfilling all those criteria of the atypical nephrotic syndrome. Then you will start directly steroid. We have discussed that when we will go for the renal biopsy. We have discussed that what alternative investigation before nephrotic start of steroid you can go to look for atypical nephrotic syndrome. That includes C3, HIV, HBV, HCV serology, ANA, anti-dsDNA. So this is very important before start of steroid therapy. Now, before starting steroid, you have to look for the TB, because the steroids can flare up the TB. For looking TB, you can do the X-ray test. You can get the findings. Similarly, you can do the PPD test. So I have a separate video on that how you will manage if PPD test comes positive. Now, the initial treatment, once you diagnose, you all through the workup. You make that patient is having a simple typical nephrotic syndrome. So how will you start treatment? You will start patient on the steroids. Steroid is prednisolone that come in the form of tablet, delta cortical 5 mg tablet. So dose is 60 mg per meter square per day. In simple way, 2 mg per kg per day, and the maximum dose is 60 mg per day. And now it is given as a 4 to 6 week, and after 4 to 6 week we switch to the 1.5 mg per kg on alter day with maximum dose of 40 mg. That is given for the period of 2 to 5 months, with minimum dose is 12 weeks. So from the start of steroid therapy, that is on the daily basis, to alternate day therapy, the total duration of the steroid therapy should be at least 12 weeks. In general consensus, the important point practically what you should do. So you will give the daily dose therapy for the 6-week period. So you will give 2 mg per kg per day for 6 weeks, and then shift to the alternate therapy, that is 1.5 mg per kg per day for the 6th period, and then you should stop. That is the practical point. 6-week daily dose therapy and alternate dose therapy for the 6th week, and then stop. If patient is simple nephrotic syndrome, his patient is responding. You can go through the definition of response, remission, relapse, all these things from the book. So 6-week daily dose, 6-week alternate day therapy, and then stop. So traditionally, the total daily dose split into 2 doses. However, single daily dose of steroid has efficacy equal to the split dosage and fewer divisor effect. So the dose you are going on daily dose or alternate dose, you will give it as a single dose. There are less side effect as compared to split dose. So the daily dose and alternate dose is given as a single dose. Along with the steroid for long term, the side effect in the form of vitamin D and mono effect, and also the steroid causes a gastric erosion of mucosa and peptic ulcer disease. So you routinely we give some calcium supplementation along with it, and we also routinely give some gastroprotective agent along with the steroid therapy. So some patients during this with nephrotic syndrome have gross edema. They need admission and they need alternative therapy. One of that is diuretic therapy. Diuretic therapy may be beneficial, particularly in children with symptomatic edema. Severe edema, like patient is having scrotal edema that is so severe that patient has severe pain and there are ulceration on it. Similarly, severe gross ascites, the severe effusion that is hindering the patient respiration. So in this case, you have to go for this alternate therapy. The loop diuretic in the form of furosemide can be given at 1 to 2 mg per kg per day, may improve the edema. Their administration, however, should be handled with care, because plasma volume contraction may later be present and hypovolemic shock may be observed, and with overly aggressive therapy. So nephrotic syndrome is hypovolemic condition. The fluid is going out from blood vessel into interstitial fluids, interstitial spaces. So if you give further diuretics, the further fluid is moving out. So patient can, although patient is edematous, but can go into hypovolemic shock. So you have to give these diuretic very carefully. Second is that patient with nephrotic syndrome, even minimal change disease can have 10% can have nephrotic this hypertension, and when we use steroid, the side effect of steroid, patient can have hypertension. So the hypertension management is very important. The drugs that we usually give during hypertension are the ACE inhibitors and ARBs. These are angiotensin converting enzyme inhibitor and angiotensin receptor blockers. They also cause renal injury, so they should be given carefully with monitoring of RFTs. Calcium channel blockers and beta blockers may also be used as a first line agent for the hypertension. Now, in severe edema, you can also go for another alternative therapy, that is albumin infusion. So it is given as 1 gram per kg body weight and given very slowly. So 1 gram per kg body weight very slowly. Indication are again those that gross ascites hindering respiration, gross effusion causing respiratory distress, grossly scrotal edema. So in this case, you will go for the albumin infusion. So important point is that albumin should be given very slowly. The side effect of albumin should be in mind, that it can lead to the pulmonary edema, it can lead to the acute injury, and it can lead to the allergic reaction, and even can cause hypertension. So these should be bear in the mind, the side effect of albumin infusion. Now, the home monitoring, that how you are going to monitor the case of nephrotic syndrome once you admit him and stabilize him and then send him to the home. How will you monitor the nephrotic syndrome? So important point at the home monitoring are that patient weight should be properly monitored, patient input output record should be monitored, and patient urine for the protein should be monitored. So urine for protein at home can be monitored in the two ways. One is a dipstick. You can teach the parents that how you are going to interpret the dipstick urine. Similarly, you can go for the urine by boiling test. So you can teach them how to boil the urine and how to interpret the labs. So that can be, then they can come with you if the urine dipstick is protein is positive or boiling protein method is positive. So weight should be checked every morning, as well as home logbook should be kept recording patient's daily weight, urine protein levels, and steroid dose of the patient is being treated. Families and patients are instructed to call for any edema, weight gain, proteinuria of 2 plus or more for more than 2 days. This is basically a picture showing the heat coagulation test, that how it is done. It is done by placing urine in a test tube, and upper part of tube is heated for a period of 2-3 months, and the coagulum is noted that shows that patient is having positive proteinuria. So when you give steroid to a patient, the side effect of steroid comes, and you should keep in mind that what are the common side effects of steroids. These include the Cushingite changes, hyperglycemia, infection, abnormal bone metabolism, skin atrophy, stria, peptic ulcer, adrenal suppression, increased blood pressure, and behavioral changes, as well recognize potentially serious adverse effects. So once you give steroids, on follow-up you will check for these adverse effects. So now the simple nephrotic syndrome was being treated as I have discussed. So now we will treat the infrequent relapser and frequent relapser, as well as steroid dependent nephrotic syndrome. So in infrequent relapser, what is infrequent relapser? So if a patient gets one relapse within last 6 months, initial response. So you get a nephrotic syndrome first time, you give steroid response. First 6 months, if you get single response in first 6 months of treatment, or 1 to 3 relapses in any 12-month period. The important is that first 6 months of start of treatment, single relapse, or 1 to 3 relapses in any 12-month period, then we label him as a case to be infrequent relapser. The frequent relapser is opposite of that we will get at least 2 relapses within first 6 months of start of treatment, or 4 relapses in any 12 months period. So that will be frequent relapser. And steroid dependent will be that 2 or more relapses while on steroid treatment, or within 14 days of tapering. Okay. And steroid resistant cases, that you give steroid for 4 weeks but patient still unable to achieve the remission. So these 4 definitions are very important. Infrequent relapser is that within first 6 months of treatment, single relapse, or 1 to 3 relapses within any 12-month period of timeline. And frequent relapser is that 2 or more relapses within first 6 months of treatment, or 4 or more relapses in any 12-month period. And steroid resistant is no response after 4 weeks of therapy, and steroid dependent is that 2 relapses while on steroid therapy, or within 14 weeks of tapering of steroid therapy. So in infrequent relapser, The treatment is that you will go with a daily dose, that is 2 mg per kg per day, and you will monitor for his urine protein. If a patient goes into remission, that is urine protein is nil or trace for 3 days, you will then stop the daily therapy. So in infrequent relapser, during relapse, you don't have to complete the 6 week. You just achieve the remission, 3 days negative protein, and you will stop the daily day therapy. You will shift to alternate day therapy, and you will give it for the period of 4 weeks. So in treatment of relapse, you will give daily dose therapy till remission and alternate therapy for the 4 weeks. Now, how you will managing the frequent relapsing and steroid dependent disease? I have already discussed the definition of these both of two, that what we call frequent relapser and what we call steroid dependent. So we will just go for the treatment option. So in this current KDIGO guideline recommend that frequent relapsing nephrotic syndrome and steroid dependent nephrotic syndrome, prednisone is prescribed at 2 mg per kg per day as single morning dose until the patient has been free of proteinuria for at least 3 days. So first you give daily dose, achieve remission. After remission, you will after remission, prednisone is reduced to 1.5 mg per kg per day as single dose on alternate therapy, and it is tapered over 3 months. So first you will achieve remission with daily therapy, and you will give alternate day therapy of 1.5 mg per kg per day. So actual protocol is that you will give for the alternate day therapy 1.5 mg per kg per day, and you will then give for the 4 weeks, and then you will keep it on the minimum level. So the patient remains in remission. The minimum level is less than 0.5 mg per kg per day or 5 to 10 milligram. That is 1 or 2 tablet on alternative therapy, and for the period of 3 months. You will note further any sign of steroid toxicity. Usually the low dose is defined as the dose that is less than 0.5 mg per kg per day. So at this dose, usually we don't get steroid side effect. So if we get relapses or even on maintaining that low dose, or we get steroid side effect, then we have to go for the alternate therapy. With frequent relapser or steroid dependent, thus require alternate therapy. The alternate therapy are cyclophosphamide, calcineurin inhibitor like cyclosporine and tacrolimus, mycophenolate mofetil, levamisole, and rituximab. So levamisole is cheaply available, easily available, and have less side effect as compared to other alternate therapy. It is given in cases of frequent relapse nephrotic syndrome. So it is basically was an anti-elephantic drug that has amine modulating effect. The levamisole given is the dose of 2.5 mg per kg. It is given on the alternate day therapy, and the duration of levamisole is minimum is 12 to 24 months. It depends upon the nature of relapsing. So it comes in the tablet name of Ketres and a 40 mg strength tablet. The recommended dosage is 2 to 2.5 mg per kg on alternate day. It is given for the 12 to 24 months while monitoring the leukocyte count. It causes leukopenia, and leukocyte count are done as 12 to 16 week, not frequently. Not frequently are done. So common side effect of this drug is the gastrointestinal symptom in the form of nausea, abdominal pain, and pyrexia. So we are discussing here the alternate therapy. You should know the alternate therapy. You should know the brands in which they are available and their strength. You should know their dosages. You should know their frequent side effects. So these are important, very important points from practical point of view as well as from the exam point of view. So next drug is the cyclophosphamide. It is predominant alkylating agent. It is used in treatment of frequent relapser and steroid dependent nephrotic syndrome. Benefit of this is that we give it for a shorter period, and the sustained remission after a defined course of treatment is there. So it is the side effects are in the form of infertility, hemorrhagic cystitis, that are very common side effect of it. Patient treated with cyclophosphamide must have weekly complete blood count to monitor the leukopenia. So one of common side effect is the leukopenia. Patient must also maintain adequate hydration and take cyclophosphamide in the morning, not at the bedtime. Families must be concealed the report of gross hematuria, fever, and severe illness. So it should be given along with good hydration, morning time, to avoid the hemorrhagic cystitis. That if you give in morning time, so you will through the day you will drink water. So the evidence will be hemorrhagic cystitis will be low as compared to giving in on the night time. So families also being concerned about the reporting of gross hematuria, fever, or severe illness. So it comes in the form of tablet endoxan and 50 mg tablet. 50 mg tablet is given in the form of. So cyclophosphamide has a bladder toxicity and other side effects such as gonadal toxicity, bone marrow depression, carcinogenesis, and increased risk of infection. So these side effects should be kept in mind while treating the cyclophosphamide. Next is the calcineurin inhibitor. It includes cyclosporine and tacrolimus. These are recommended as initial therapy for children with the steroid-resistant nephrotic syndrome and also given in the frequent relapser and steroid dependent. Children must be monitored for the side effects. The side effects of calcineurin inhibitor are that hypertension, nephrotoxicity, hirsutism, gingival hyperplasia. And also these cause renal damage, so mostly we go for renal biopsy before start of these calcineurin inhibitors. I forgot to mention that cyclophosphamide is given for the period of cyclophosphamide is given for the period of total 8 to 12 weeks. It is given as a period of 8 to 12 weeks. Cyclophosphamide is given only up before starting cyclophosphamide. In cases you want to shift this alternate therapy, you will first, in case of levamisole, cyclophosphamide or calcineurin inhibitor, you will first achieve the remission with steroid daily dose, that is 2 mg per kg per day. Once you achieve remission, then you will go for the alternate therapy, that can be levamisole, cyclophosphamide, calcineurin inhibitor. And however, in these cases, especially in case of calcineurin inhibitor and in case of levamisole, you will continue steroids along with it on alternate day basis, that may be 5 mg or 10 mg. So you will continue 5 or 10 mg steroid along with it. This is very important point. The dose of the cyclophosphamide is given at the dose of 2 to 3 mg per kg per day, and it is given for the period of 12 weeks. 12 weeks period is given. After 12 weeks, the cumulative dose is complete and it will cause toxicity. So cyclophosphamide is given at 2 to 3 mg per kg per day and for the period of 12 weeks. And in cyclophosphamide, usually we don't need alternate day steroid if there is no recurrence on the drug. So we were discussing the calcineurin inhibitor. The calcineurin inhibitor includes cyclosporine and tacrolimus, and we have discussed their side effect and we have discussed their usage. So first we discuss their important. Those calcineurin inhibitor are useful steroid sparing agent. These agents can also be used in children who fail to respond to subsequent relapses after treatment with the cyclophosphamide, in children whose families object to use cyclophosphamide because of gonadal toxicity. These appear to be no difference in efficacy after 1 year between cyclophosphamide and cyclosporine. So disadvantage of calcineurin inhibitor are that prolonged course of treatment are needed. Nephrotic syndrome tends to reoccur when treatment is stopped, and nephrotoxic injury, so the renal injury. Consideration should be given to kidney biopsy after prolonged treatment to monitor the calcineurin induced nephropathy and fibrosis. Mostly we go for biopsy before start of these calcineurin inhibitor. So first we will discuss the cyclosporine. It is given at the dose of 3 to 5 mg per kg per day, and this is given as a divided 12-hourly dose. And the drug monitoring is done to avoid the side effect. Kidney function are also carefully monitored while giving the cyclosporine. Low dose steroids are continued for a variable length of time. As many as 40% of patients may need to maintain on steroid during cyclosporine treatment to maintain remission. So you along with the cyclosporine, you will also continue the steroids. This comes in the capsule form, and that is Sendimum or cyclosporine Neurol and 25 mg capsule. Tacrolimus is also given as a dose of 0.1 mg per kg per daily, and it is given as a 12-hourly dose. And also we monitor the drug level, RFTs here, and we also give low dose steroid also along with that to keep the patient in remission. It comes in the form of a capsule, that is Inograph tacrolimus capsule. It comes as a 1 mg, 0.1 mg, 0.5 mg capsule is the form capsule. So the tacrolimus reduces the risks. The difference between cyclosporine and tacrolimus is that tacrolimus has less cosmetic side effects. So you can give in the females that we are concerned about cosmetic effect in the form of gingival hyperplasia and hirsutism. So it is less associated with the tacrolimus as compared to the cyclosporine. So we will revise all that we have learned here. That first you diagnose nephrotic syndrome. Second, you make sure that patient is having primary nephrotic syndrome and there are no atypical features. If patient is having primary nephrotic syndrome, there are no atypical features, then you will look for the TB. If there is no evidence of tuberculosis in the form of normal X-ray test and PBD test, then you will start steroid therapy. In the first case, you will give daily dose 2 mg per kg per day, maximum 60 mg for a period of 6 weeks, and then you will give alternate dose, that is 1.5 mg per kg per day for the period of next 6 weeks, and then stop. In case of relapse, our patient is infrequent relapser, you will first give him the daily dose, that is 2 mg per kg with maximum dose of 60 mg per day for period till achievement of remission. Once you achieve remission, you will stop this daily therapy. No need of 4 week or 6 week. Just achieve remission and stop daily therapy and shift to alternate therapy, and alternate therapy is given for the period of 4 weeks. Now if patient is having frequent relapser, again you will first achieve the remission by the daily dose, and then you will shift to alternative therapy, and you will taper off alternate therapy. You will not stop here. In case of frequent relapser or steroid dependent nephrotic syndrome, you will continue alternative therapy at lower level, that can be 0.5 mg per kg per day on alternate day, or 5 or 10 mg tablet on alternate day. So you will maintain at that for the period of 3 months, and then you will hold it. If patient needs alternative therapy, if patient is having not able to maintain his remission on the low dose steroid, the steroid dose is required to be maintained on remission is more than 0.5 mg per kg per day on alternate day base, our patient is having side effect of steroid, then you will go for the alternative therapy. That can be usually we start in case of frequent relapser levamisole, and in case of steroid other drugs like cyclophosphamide, calcineurin inhibitor can also be started. For levamisole, you give it on alternate day, your dose is 2 to 2.5 mg per kg per day, single daily dose, and it is given further to help to 24 month of period. The protocol here is that you first achieve, for all the alternative drug, is the protocol is that you achieve remission always with the steroids. You give him steroid for the period of for the variable period till achievement of remission, then you stop the steroid daily dose therapy, you start alternate day therapy of steroid along with alternative drug, that can be levamisole, cyclophosphamide, or calcineurin inhibitor. You in the case of even levamisole and also in the case of calcineurin inhibitor, the alternate dose therapy is given for the 4 week at the dose of 1.5 mg per kg per day, and after that you will lower down this dose to the minimum dose, that may be 5 mg or 10 mg or alternate day therapy along with alternative drugs, and you will continue it. The duration of the levamisole is 1 year. The duration of the cyclophosphamide is 8 to 12 weeks. The duration of calcium inhibitor is also 1 to 2 years. Levamisole is given an alternate day single dose. Calcineurin inhibitor are given on the daily basis, 2 doses, divided doses, and the cyclophosphamide is given as a single dose, morning dose. So from this concept, you can also, if patient, you taking the history from the patient, you can also tell that which type of therapy patient is. If patient is on alternative therapy, then it will be levamisole. If patient is on the daily morning day therapy, then it will be cyclophosphamide. If patient is on the BD dose, that it will be the calcineurin inhibitors. So in this way you will do. And also important thing is that you will go for the renal biopsy before start of these calcineurin inhibitors. Renal biopsy, if some drug is started and before that you patient tell that you are going for the renal biopsy was done, then this drug is most likely a calcineurin inhibitor, that can be cyclosporine or tacrolimus. Similarly, if patient tells that they are asked to do the weekly basis CBC, then that drug is cyclophosphamide because it causes leukopenia, and we hold this drug if TLC count is less than 5,000. So I tried to briefly review and practically tell you that management plan of nephrotic syndrome, that you can yourself manage if a patient comes with nephrotic syndrome, that how you are going to manage a first episode of relapse, of infrequent relapser, of frequent relapser. However, important point is that if you get a case which is steroid dependent, which is steroid resistant, as well as if patient is a case of frequent relapse or steroid dependent, and you start on alternative therapy and on alternative therapy, and patient relapses on alternative therapy, then you have to refer him to the pediatric nephrologist for the better management. Thank you.